In this video, we're going to discuss xerostomia as a result of radiation therapy for head and neck cancer. So, xerostomia or dry mouth is one of the major side effects of head and neck radiation for head and neck cancer. And it's experienced to a smaller or greater extent by pretty much everyone that undergoes radiation therapy. Some people have very mild xerostomia, and some people have very severe xerostomia. But saliva is one of these things that until it's gone, you don't really miss it and you don't understand how important it is. But with radiation, what happens with the radiation is the radiation damages the salivary glands. There's three major salivary glands in your body: the parotid gland, which is like here on the side of your face, submandibular gland underneath your jaw, and sublingual glands underneath your tongue. There's thousands of minor salivary glands all over your mouth as well. And then when radiation is given to treat the cancer in this area, the salivary glands are basically collateral damage and they stop functioning very well. And so, what happens to people after they undergo radiation and get xerostomia? They have problems with chewing, with changes in the flavor of their food, swallowing, and speaking. They have an increased susceptibility to having caries or dental cavities, gingivitis, spontaneous bleeding of their mouth, periodontitis, oral and oropharyngeal infections, halitosis, bad breath, ulcers, and dental plaque formation. Then they have dry lips, absence of saliva on the floor of the mouth, pale and cracked oral mucosa, and the papillae atrophy, and then you get erythema and kind of this smooth look of the inside of the mouth and the tongue, which is not normal. And they can have pain and difficulty wearing dental prostheses. So it's a major problem. It causes significant impacts on quality of life. And it's one of the things that patients have to deal with for a long time, pretty much lifelong after radiation therapy. This is a recent paper published in 2019, which I think is kind of the best overview of treatments and where the field is for xerostomia. And we'll kind of come back to this. Basically, here's a graph showing what happens to saliva during and after radiation treatment. So what happens is before treatment, there's a basal amount of saliva that's always produced in the mouth, and then when we eat food, it really cranks up so we can chew and swallow the food. And so this is normal before radiation. Then during radiation therapy, there's a precipitous drop in the stimulated flow, and actually a very large drop in the basal flow. And then after radiation, 1 to 3 months and 3 to 6 months, that's when it's the worst, very dry. And then there is some recovery over time. Okay, so this is a paper that looked at the very late effects. They kind of followed people for over 8 years for the major side effects of radiation therapy, which are dysphagia, xerostomia, and neck fibrosis. So if we look down here, okay, the way to interpret this graph is the light colors are kind of mild symptoms, and these darker colors are the more severe symptoms. So what you see is at 1 year, in terms of dysphagia or difficulty swallowing, it's pretty bad. You see a lot of these dark colors. Then it gets better for about to about year 4 or 5, and then after year 4 or 5, the dysphagia actually gets worse. So it gets better and then it gets worse. Xerostomia gets better for like 3 years, and then what it kind of bifurcates. There's a few people that get worse, and then a few people that get better. But overall, it's fairly stable after about 4 years. So you get kind of recovery for 3 years, and then after that, it's relatively stable for most people. A few unlucky people, it gets worse, and a few luckier people, it gets better. But xerostomia is generally stable. And then neck fibrosis, so the amount of stiffness that people have in their neck, and when they feel their neck, it's not the tissue isn't soft; it's kind of firm. That gets better for about a year, and then it continuously gets worse over the next 8 years, and probably continues to slowly get worse over time. So xerostomia has this kind of like, it gets better for about 2-3 years, and then it's relatively stable. So in terms of treating xerostomia, there's the prevention side and then there's the treatment side. So prevention side is what are things that we can do during the radiation therapy to try to prevent people from getting xerostomia quite as bad. A couple of things have been tried. These are free radical scavengers. There's a drug here called amifostine, which is a free radical scavenger. And there's multiple other free radical scavengers that have been tried. Here's a paper talking about using vitamin C and vitamin E, which seems like a very good idea and seems very safe. And in this paper, they said that it did seem to suggest that it helped xerostomia in this case. So these free radical scavengers, they do help because they decrease the damage that the salivary glands take from the radiation. Here's the downside of using these things. The way that radiation works is it generates free radicals, and that's what damages the DNA to kill the cancer. So if you give medications that are antioxidants or free radical scavengers, there is a possibility that it will make the treatment against the cancer less effective, that the radiation just will not work as well as the cancer because these drugs are basically stopping the way that the radiation works. So I'm not real sure that I feel very comfortable recommending that. There is another set where you have an agonist, so you have a drug that makes people produce more saliva. The idea behind this is that you just increase salivary flow during the radiation treatment, and then that will help people have continued salivary gland function after the treatment is over. So they use pilocarpine, and several other drugs have been tried, and these do seem to help. The problem is in these studies, almost half the people stopped the study because the side effects of the radiation, the side effects of the drugs were too much. And, people that have gone through radiation therapy understand that radiation therapy alone is really tough to handle. It's a very difficult treatment regimen to get through. And then adding more things to that is just a lot to handle. So people have a hard time tolerating this pilocarpine and other drugs because they have side effects. Then another way to try to prevent it is this thing called salivary gland transfer. This is a surgical procedure where the surgeon takes the submandibular gland from here and then transposes it to kind of underneath the chin, and then that's shielded during the radiation therapy. This seems to be pretty effective. There's a couple of downsides to this. It is surgery, so if you weren't undergoing surgery for cancer treatment, you were going to get radiation treatment as your only treatment, then you're undergoing a surgery and delaying your care as you wait for the surgery to be done. Number two, there's a couple of possible complications of the surgery. There can be damage to the nerve that goes to your tongue, helps you taste and feel and move your tongue. Those are two separate nerves, but they're both in that area. And then there's small risks of the surgery, like anesthetic risks, bleeding, infection, those kinds of things. And then they have to shield that area, and there's a small chance that there may be some cancer-positive nodes that are being transferred along with the gland, and those would be shielded, and there's a slightly higher risk of, it's very minimal, I would think, but there's a chance of transferring some cancer cells along with the submandibular gland and protecting it from the radiation, which is not something that you would want. The studies that have been done they didn't show a dramatic increase in cancer recurrence or anything bad like that, but it is another surgery, but it does seem to help. So that is something that might be considered if your surgeon is kind of willing to do that or is comfortable doing that, but it's not a widely used technique, but does seem to be effective in causing xerostomia, with the downside of some possible surgical complications and some possible increased cancer recurrence. Now, I think one of the reasons that probably this is kind of growing out of favor is what they can do. Rather than just moving the gland forward and shielding it, they can use more advanced radiation planning techniques and try to spare radiation from hitting the gland on the opposite side of the tumor. And this is a technique that seems to be fairly effective. So this one doesn't have the downside of surgery, and they've checked to see if sparing the contralateral submandibular gland gives you higher risk of cancer recurrence, and it does not seem to be the case. So xerostomia remains a significant morbidity despite parotid sparing. So they've already tried to spare the parotid, now they're going to try to spare the contralateral submandibular gland. And then these data provide important preliminary evidence that contralateral submandibular gland is feasible and can be safe even in locally advanced cancers. And this one, they found that contralateral submandibular gland sparing IMRT. IMRT is the technique of radiation that they're using to try to spare it. So you can see in this picture that they're going to radiate this area to a high dose. This is the cancer side, and they're going to try to spare this submandibular gland on the opposite side. So it did not increase marginal failure rate, so the cancer recurrence did not seem to be any worse in these techniques. So this is probably a superior technique to doing a surgery to try to transfer the submandibular gland to another spot. This is another paper which I thought was quite good, looking at treatment of late sequelae after radiation therapy, and the late sequelae that they are dealing with is mainly xerostomia, dry mouth, dysphagia, and osteoradionecrosis, trismus, and hearing loss. So these are the more common treatment effects after radiation therapy for the head and neck. And again, they talk about how radiation therapy, how it causes this problem. And so now we're moving on to the kind of the treatment method. So, we've already undergone treatment, and people have survived the treatment and they're cancer-free, but now they're dealing with this xerostomia. What are some methods that can be used to deal with it? So in terms of drugs, pilocarpine is the most studied drug, does seem to be effective. There are some side effects with it that need to be thought of. And so, the main problem related to pilocarpine is that as soon as you stop taking the drug, the problem comes right back. And there are some adverse reactions to the drug, such as bronchospasm. So that's like tightening of the pathways in your lungs, bradycardia, which is slowing of your heart rate, vasodilation, which can give you kind of lightheaded feeling, and diarrhea. And then in reported studies, that these side effects are fairly common, although they're usually not that bad. But you can have like sweating, flu-like symptoms, and urinary retention symptoms. So, I mean, there is a trade-off with this every medication has a trade-off. Every medication has some side effects. So they have the good effect, the one that you want. So pilocarpine, the good effect is it does help people produce a little more saliva and have less xerostomia. But it has a multitude of other side effects. And in some people that have heart and lung problems or eye problems, they need to be careful using this drug. So in terms of drugs, pilocarpine is probably the most studied, and it's known to be effective. And so if people are having problems with it, that's something that definitely should be tried to help their quality of life. Other things that can be tried is obviously things like synthetic saliva. The one that I usually suggest is Biotine, but there are many other brands, and they're all over the counter. People can try them. The effect of these artificial saliva preparations do not last long. I mean, a few minutes at best, I think. And so they're pretty expensive, and they don't last very long. So what most people do is they end up just having a bottle of water and just sipping on it all day. And that seems to be the way that most of my patients handle it. But of course, it's not ideal. There is a paper that I found about using coconut oil, which seems like it's a very safe method. There isn't too much side effects with using coconut oil. And what these people did is they suggested that people use a little bit of coconut oil and coat their mouth with it from time to time. Let me see what their exact study protocol was. Okay, so here we go. A suggested regimen of coconut oil was prior to meals and at bedtime, with the individual coating his or her mouth with the product at each application. However, participants were unrestricted in their use when invited to titrate its frequency so they could use it as often as they wanted, and they were asked to use this coconut for a 2-week period. And in this paper, they found out that it was people seem to like it. So I think this is a very easy and safe method of dealing with it. That might be helpful. Another thing is sometimes people chew gum, and because the whole chewing mechanism helps stimulate saliva flow. So chewing some kind of gum, usually with xylitol or some kind of alcohol-based sweetener, is usually the most effective. And then other treatment methods are using hyperbaric oxygen. This is a systematic review of hyperbaric oxygen treatment. And the quality of the evidence isn't great. And these are 2 studies that they looked at. And it does seem like, here's the darker line is the hyperbaric oxygen chamber. So these people definitely seem like they're doing a little bit better. And then if you look at how sticky they felt their saliva was, the people felt like that got better. These changes aren't dramatic and did not reach statistical significance, but there is a trend. And if this option is available to you and the patient's willing to undergo the treatment, which is usually at least 20 sessions in the hyperbaric oxygen chamber, and if insurance covers it, then it might be worthwhile for people that are wanting to try this. Another thing is people have tried acupuncture, and if there's a person in your area that does acupuncture for this reason and they know how to do it, there's kind of conflicting evidence, but most studies show that it might be helpful. So that's another thing that might be tried. And then there's this thing called an Alton's unit, which is transcutaneous electrical nerve stimulation units. And this is another thing that has been shown to be useful. And with this and the acupuncture, the effects last after the treatment ends. So it's not like pilocarpine. As soon as you stop the medication, things go right back to where they were. With these therapies, when they do work, they seem to be a little bit longer lasting and have a little bit more durable treatment. So let me go back to this paper we started out with and see if there's anything we didn't talk about. Yeah, so we talked about this pharmacologic sialagogues. This is the pilocarpine. So we talked about acupuncture. Gustatory and masticatory stimulation. This is like having lozenges or gum to do it. And then the TENS unit, hyperbaric oxygen, we talked about that. And this is like using aloe vera, coconut oil. So these are probably things that should be tried. They're very low risk. And I think that would be good. Okay, and then here's the last thing that this is kind of the holy grail. If we can do some kind of stem cell therapy or gene therapy to try to regrow people's salivary gland function, this is very preliminary stuff, and they're doing work in mice. So if this were to happen, this is many years off. But this is kind of the latest thing that people are working on. So I hope this video was helpful to some people. So there's 2 stages, things that we can do to prevent it. And in my opinion, the thing that is kind of the most promising in terms of trying to prevent it is the better IMRT techniques to try to spare the contralateral submandibular gland when that's possible, while still effectively treating the cancer. And then in terms of treatment, things that are easy to do are like things like coconut oil. Pilocarpine obviously is proven to work, but you have to deal with the side effects of that medication. And then hyperbaric oxygen works in some people. These TENS units work in some people. And acupuncture, if there's someone who is familiar in doing acupuncture for this problem, is also helpful. If you have any questions or comments, please comment below. And thanks for watching.